to control progression of axial myopia in children. The authors have no financial interest in any of the products. So atropine, we all know, has been used in various formulations and is known to reduce the progression of myopia. Post Atom 1 and Atom 2 studies, that is atropine treatment of myopia studies, there has been a significant rise of usage of low concentration atropine and a renewed interest in atropine for progression of myopia. However, there are no specific studies done in Indian eyes on low concentration atropine eye drops. So why low concentration atropine eye drops? Minimal to no effect on accommodation, that is most important. Second, there is no photophobia. Chances of systemic side effects like fever, flushing, etc. are almost nil. The retardation of progression doesn't seem to be dose dependent, as we will see in our paper, and is therefore comparable. And now it is commercially available, so there is easy availability. The theories as to how atropine prevents the progression of myopia is on debate. One of the first theories was that it may block the accommodation and therefore reduce the protective effects of excessive accommodation of progression of myopia. With atropine 0.01% being equally efficacious, it is thought that it is actually the atropine which affects dopamine neurotransmitter release from the cellular stores, and this may actually influence retinal signals that control the growth of eye. So this is the current theory going round. So with this literature backup, we did a randomized controlled trial for 3 years duration. Institutional ethical approval was taken, and consent was taken from parents after explaining them in detail regarding the drops and the fact that it was actually being reconstituted and was not commercially available. 2 groups, one with 0.01% atropine eye drops once in evening, another group with no intervention was taken. Age match, power match controls were included, and the range of age was 5 to 12 years. Spectacle power was between -3 to -8, which were included in the study. All the patients were children who were actually being followed up in our clinic and had showed documented progression in glass prescription, at least 0.5 or more than that. No placebo was controlled, prescribed to children who were controls, and axial growth was measured at 6 months interval. How did we reconstitute atropine eye drops? We took commercially available 1% and diluted it with commercially available lubricating eye drops to appropriate 0.01%. Now it is commercially available, but 3 years back when we started the study, there was no commercially available drops, and so we had to reconstitute them. A total of 60 children were taken in 2 groups, 30 in each group. The mean age was comparable in the 2 groups, and the mean axial length was also matched and comparable. So this shows the results of our study. You can see that this blue line is showing the atropine group, which has got very minimal growth in terms of diopters at the end of 3 years. And you can see that this particular control group has much larger axial progression compared to this from the baseline. So it controls the progression. And this is the per year breakup of atropine group and control group. You can see that it has reduced to almost 0.2 per year, 0.27 per year at the end of 3 years. Whereas the control group, this is in millimeters, this is the axial length, and this is the dioptric difference at the end of 3 years, and this is for the control group at the end of 2 years. So it does not completely block the progression, but it definitely retards the progression. Our results are comparable with the only study which was published recently, 6 months back, by Dr. Kothari in IJO, where he had used higher concentration, 1% concentration atropine, and where he showed that the progression of dioptric progression reduced from 0.6 to 0.2 diopters. And our studies are also comparable to Atom 1 and Atom 2 studies, which compared various concentrations of atropine and showed that there was a reduction in progression of myopia over a period of 2 years. So we conclude by saying that reconstituted atropine, 0.01% eye drops are safe and are effective for preventing the progression of myopia. We believe that this is one of the biggest interventions in the last few decades, especially after Atom 2 studies, that it controls the progression of myopia in children with very minimal side effects or with no side effects on their accommodation, photophobia and systemic problems. However, we need few more comparisons and indications, if at all, for switching to higher concentrations. Thank you.
Dr. Are you on? Is the mic on? Yeah. Dr. JETHANI, did you also record how many hours of outdoor activities these children were doing?
No, sir, we did not do it.
because that has been also proposed as a
Very
reason,
true, very true.
and that would be a confounding factor over here.
It could be confounding factor. It could be the reason why it does not completely block the progression. The whatever progression is still occurring could be because they are in the house. It is myopia is multifactorial. Yes. So it could be possible that they are indoors more time, and also the lightning, the effect of lightning. Nonetheless, even if comparing all the factors, keeping them as similar, we still can say that there is some effect of atropine 0.01%. So this was a RCT. This was a pure RCT, but we have a larger series where we have not done RCT. We have just prescribed them like to almost 300 children, and it works in those. But since this was not with this paper, I have not presented that data.
So if you are publishing your work, I would encourage you to include that as a
confounding factor.
Confounding
Yes.
factor. Thank you. Good paper. Thank you.
Sir.
Congratulations.
Thank you, sir.
Paper. I'm just checking whether your controls were age matched and
They were
matched for heredity.
No, they were not matched for hereditary. They were matched for age and power.
But isn't that important?
It is important. So myopia is obviously, there are multiple factors. There could be age and power was easy to match. Hereditary, and then it is a long-term study. We have studied for 3 years follow-up. So a lot of patients actually drop out when there is such a large follow-up studies, especially in India. It becomes difficult to have a lot of patients in the group when there is such a long-term follow-up studies.
No, are you giving?
I agree with you.
Are you giving an excuse for?
No, sir. I am agreeing with you.
In one line, what new information did your study provide which was not already in literature?
So our study was the first study in Indian population. The information was
Second study, because
no. The first study was on atropine 1%, and 1% we know that it is not. We can use it, and we have been. So 1% is being used since last 40 years. We all knew that it is useful, but we were not able to use it mainly because of the problems of accommodation, and mainly because of problems of photophobia and systemic side effects. This study tells us that 0.01% is safe, and there are not multiple side effects, with the added advantage that it actually blocks the progression. So that is the important finding.